Moving on, we have our third panel, which is Para-Endocrinology, issues surrounding clinical endocrinology. Endocrinology is so much more than what meets the eye. This panel will walk us through the issues surrounding clinical endocrinology that often go unspoken. With that, I would like to welcome the moderator of the panel,
endocrinologists or trainees or other doctors would come across. When you come across patients with thyroid or other endocrine, proper endocrine disorders, what should you know? What are the things that nuances that you need to know in practice before you refer or after you refer to an endocrinologist? So I've pinned down the topics to very small issues, like what are the issues in the management of hypothyroidism. Low testosterone is not always hypogonadism. We see a lot of these sexologists who check testosterone middle of the day or in the evening and start treating it. So how will we avoid that? Dr. Ravi will address that. Hyperprolactinemia is always not a prolactinoma. What Dr. Prithviraj has to say about that, and how do we test for pheochromocytoma? When do we actually suspect it? And Dr. Smita Nalla will talk about that. We're not going to details of these endocrinology cases, just the little aspects of it. And how is the cortisol testing? How is the right way to do it? Next slide. Right. So I'll be talking about thyroid function test sampling. A lot of us have a question about when do we actually sample? Is it fasting or is it any time of the day? It's not actually recommended by any guidelines that we should do a fasting thyroid hormone sample. Yes, there is some diurnal variation, as you can see in a lot of, like almost 450,000 volunteers. They did a retrospective analysis of samples which were done across the time, and you see that there is a dip in the value of the TSH during the day, and then it goes up again late during the night, and it peaks somewhere around 5 a.m. or 3 a.m. So we don't know what the reference range that we have. We have been given a lot of reference range based on what the different labs are. We don't know what the time of that is. What I believe is that if you look at the subset of patients that we check the TSH, overt hypothyroidism, the TSH is 40, you don't have to worry about fasting, so you can do it anytime. Already on medication, probably wouldn't make a difference. Again, you can do it anytime. Hyperthyroid patients, doesn't matter, you can do it anytime because the TSH is going to be suppressed anyway. Subclinical hypothyroidism is the only it's a subset where you can have slight change. But still, if you do the 9 a.m. sample, you're only going to overdiagnose, but you're not going to miss any subclinical hypothyroidism. That is what I feel, that is what I've researched, and that's what I came to. And whether the tablet to be taken or not really doesn't make a difference. You can take the tablet. The tablet is only going to affect T4 concentrations very slightly, but TSH will not matter. The only thing to make sure is that the patient is not on biotin supplements a few days before the sample, because that can interfere with the assays, but that's very rare. So patients will not be on that. So which test to check, which is the TSH or total T4 or total T3. As per the guidelines, American Thyroid Association guidelines and many other guidelines, TSH is the only marker which is to confirm the diagnosis and to monitor the treatment as well. TSH is the only best marker. The problem is different lab gives different TSH value. How will you conquer that? This was the top right. The top right, if you see this was done part of the ATA guidelines. They checked the same sample in different labs, 10 to different labs of major companies that give us the TSH values, and they found that there is a lot of variation. If you see, there is 15 to 30% variation in that, and that is expected. So we cannot do anything about that. Even the higher, if the higher centers have this problem, and definitely we will also have. So we have to just go by clinically. What is the clinical relevance of that? Is it the total T3 or free T4 we use? Again, the guidelines recommend free hormone analysis is the most likely better biomarker for hormone action rather than the total. Total is just a very little, the total is actually 99% of it. The active hormone is actually what we want. And in hypothyroidism, you don't even want that. If in doubt, you check free T4 and free T3. And in hyperthyroid, you always check free T4, free T3, not total T4. Again, high total T4 and total T3 are normal in pregnancy. So please don't worry about that. We get a lot of referrals from gynecologists with high total T4, total T3. This is completely normal because of their rise in the thyroid binding globulin, that is estrogen driven. It is very normal. As long as the TSH is normal, you don't have to treat. Free T3, free T4 is generally not required unless it is hyperthyroidism. There are some caveats in the treatment of hypothyroidism. Before that, I want you to, we'll go to the thyroid antibody section. TPO antibodies are the most specific. They have 95% specificity and sensitivity. Antithyroglobulins also have a sensitivity, but they are only very limited in their specificity. But we generally check both. The follow-up of these antibodies is generally not required. It is only for diagnosis, positive or not. In UK, we used to get a value of positive. That's all. We never got a value of how much it was. Here, the patient comes running to the clinic, sir, antibodies are more than 1,000. It doesn't make a difference. If it is 1,000 or if it is 100, it is positive or not. That's all we want. It's most useful in subclinical hypothyroidism in patients who are trying to conceive. That's where the whole whether to treat or not will come into picture. And TSH receptor antibodies doesn't have to be checked regularly, only in Graves' disease. So coming to the treatment caveats, simple, if the TSH is normal, please continue the same dose. A lot of doctors, a lot of primary physicians reduce the dose if the TSH is normal. Please avoid that. Annual follow-up is the only thing that is required once the patient is stable. Unless they are going through puberty or planning to conceive or are pregnant, you have to check them regularly. Otherwise, once a year is absolutely enough. Post-thyroidectomy patients or thyroid cancer patients who are followed up, their TSH has to be suppressed. So please leave it to the endocrinologist. Don't tinker with the doses. In secondary hypothyroidism, where the patient is actually hypothyroid because of a pituitary cause, the TSH is not useful, and please leave it to the endocrinologist. Now coming to what is the proper diet in restrictions in thyroid. I went through all the guidelines. There is nothing to suggest that you should actually eat cauliflower or don't eat cauliflower. You eat iodine or don't eat iodine, soya, milk, meat, absolutely nothing. Thyroid is not a diet-induced disease. Once you develop a hypothyroidism, autoimmune and thyroidism, I tell this to the patient, your gland is dead. Whatever you eat doesn't make a difference. So what's the point in dieting? So there is concept of goitrogens and all, but we are dealing with an autoimmune thyroid disease which has no diet restriction whatsoever. Same thing, there is no supplements. A lot of patients say, sir, we have to take calcium for the rest of our life. No, I don't know where they get it from. This is from the ATA guidelines. There is nothing to recommend anything which as a supplement to the thyroid or any diet modifications for thyroid. When taking the thyroid, this is something that we have to tell patients, because we see in clinical practice a lot of these things where they don't store it properly. My personal experience, my mother used to store it on the fridge. She went up to a dose of 200, 250. I got to know that was the problem. I reduced it to, stored it at a different place. We reduced the dose to 100. So storing it on the fridge, storing it in the kitchen, not taking it empty stomach. If you have to take it with a little sip of water, that is also actually, I'm surprised a few actually case reports are there, or people who have studied. With one sip of water, that's all you need. If you take more, your pH is, gastric pH is altered, thyroid will not be absorbed properly. So we had a lot of patients who use big doses, and we modified this things, how they take, and definitely that made a difference. Only a few supplements which are which reduce the absorption of thyroid, calcium, iron, and PPI is maybe, there is contradictory case studies to suggest this, but we always say that avoid any of these tablets when you're taking the tablet, at least 4 to 5 hours gap between these two. So with that, that's all from a thyroid nuances point of view. I just want to get the panel's idea about, panel's opinion about, you have the mics with you? Yeah. So you're free to comment about anything you want. So, Dr. Ravi, thyroid diet, do you, we never got this question in the UK, right?
No, I think we've never had it, but I think what the patient expects is you say something about it. If you do not say that this doctor does it, he says the chat GPT says don't take cabbage, cauliflower. For the sake of it, I'd say you take it, but less of quantity. Right. So there's a peace between you and the patient. Okay. And there's a guarantee that, oh, Ravi Kumar is very good because he suggested not to eat cabbage, cauliflower. I get a lot of calls in the evening that it's an emergency. I says, what happened? I had cauliflower Manchuria. I said, just wait. I said, just wait for it. It'll be fine. So I think what is the patient's perception and what are you expecting it? Right. If you do not say that, I think in India, we like to say, you need to say something about the diet. Right. In UK, we have a lot of evidence. But when you tell, okay, you eat a bit of less cabbage, cauliflower, there is a bit of peace between you and the patient.
Now I know why your practice is so busy. Okay. So, do you agree with precautions while using thyroid? Do you come across these patients, Dr. Prithvi, about whether they're taking with a lot of water, they sometimes they have a cup of tea afterwards? Any questions from the audience? Please be ready. We'll take the question.
Yeah, with the emergence of social media, now we have more and more myths to burst as a clinicians. Many of the people take lime water, liters of lime water in the morning, and they take their thyroid tablet, and they come up with a high TSH, and they ask the question, why my thyroid is not getting controlled. And some have few misconceptions like, I should not take milk, I should not take ragi, I should not take gluten. It is not a universal blanket avoidance for all the patients. If you are allergic to any certain things, just avoid those foods to decrease the gut inflammation. Otherwise, you don't need to avoid any food in perspective to thyroid. But as sir rightly mentioned, limited amount of water, maybe a glass of water with a thyroid medication is more than fine, but not liters and liters of water.
Anything you want to add?
Yeah, the same. Regarding the diet part, definitely, as Sir said, many people will be asking about the Brazil nut, and they'll be taking 2, 3, or 4, 5 Brazil nuts per day, because the Brazil nut contain almost double the dose of selenium what we require in a day, single Brazil nut. If they eat like other nuts, that ultimately patient may end up in selenium toxicity that is even more dangerous. So diet, and one thing we need to tell the patient is that thyroid is not a dietary disease, it's an autoimmune disease. Of course, there are some microplastics, all those things can influence the autoimmune condition, but the microplastic source is from the pollution, the water, which those things are not in our hands. The things that are in our hands is the clean diet. Of course, diet means the healthy diet, not these restrictions and all. Like as Sir said, the cabbage, cauliflower, everything they can eat. Only thing is, even if they contain goitrogens, even if they want to take more frequently, only thing, boiled or cooked form decreases the 80% of the goitrogens. So if person is taking more raw form daily basis, then maybe we can ask them to restrict but otherwise there is no solid evidence. But by the mechanisms, because they contain thiocyanates, blocks the sodium hydrates importers. So everything, I mean, because Indians, especially South Indians, they will not be taking those kind of vegetables in raw form in a daily basis. Just to make sure that we also have some knowledge to give that confidence, we need to tell all these things.
Thank you. You want to add?
Just one thing to add to that. Be prepared for the question, can I eat Brazil nuts? Is it going to improve? I don't know where this craze about Brazil nuts and thyroid is. Second thing is for obstetricians and physicians here who tend to prescribe iron and calcium, please guide your patients as to the timing of the tablet. It does make a difference with regards to when you give them, especially when they are on thyroxine.
Thank you. We'll move to the next session. Any questions from the audience?
Question these days, patients are asking about the iodine and iodine salt. Is iodine in the salt another reason for having hyperthyroidism?
Hyperthyroid.
What is your take? I'm interested to know what you generally counsel your patients on that. I will tell my opinion after you tell.
So basically, if it is all depends on the antibody status of the patient. If they already have a TSH receptor antibody or any other antibody which is making them prone to hyperthyroidism, extra iodine will only make that, it will only unmask it. That's probably my opinion. Even if they don't take the iodine extra salt, they'll probably have the hyperthyroidism at some stage anyway.
So you're saying iodine may not be the direct culprit here, but maybe an add-on effect if there is already an influence of a hyperimmune or an autoimmune process going on already. Yeah. That's what I agree also. There was a paper by Dr. Shashank Joshi, latest in ACE, he got an award in the latest ACE at Las Vegas, on role of iodine in new hyperthyroidism. Right. So he does mention iodine, too much iodine intake plays a role here, because there's too much hype on the iodine salt. Plus, our India is now, from last 47 years, iodine replete country. We have iodine in all the fertilizers and all the animal food, and that's why we are iodine replete country. We have enough iodine. We are not an iodine deficient country anymore that you need to iodinize your food with iodinated salt. So the iodine in the salt may be a bit extra in those particular group of people who have a hyperimmune or autoimmune process already in the going, maybe. So there is a mixed opinion here, and many people talk about it too much in the clinics. One more question I had for you. What do you generally do for those people who are euthyroid in symptoms, take the dose properly? Their TSH is always slightly high, like 15, 20, 30 range. But ironically, their FT4, FT3 are perfectly normal always. No matter whether you want to tweak the dose a bit up or down, FT4 is normal, TSH is a problem, and the patient questions you that the TSH, there's some TSH receptor sensitivity issue here, and you are ignoring the TSH, keeping in view their general health and FT4. But you do get questioned by the patient and the treating other doctors, especially in the case of, pregnancy planning or a young woman.
TSH is 15, you said, or 5?
15, 20 range. I'm seeing more and more of that these days with this highly sensitive TSH reporting, and also FT4 and FT3 in place are normal, always. So these are my chronic patients who have been dealing with for like 10 years already, and always the TSH is high, but all the time the FT4 is normal.
Yeah, but free T4, if the TSH is more than 10, it will classify as overt hypothyroidism.
Yeah,
but,
of course.
If
and
the
their
antibodies
TSH is like 20, 25. So is there any particular subset where we can do a genetic study on them, or a TSH receptor sensitivity study? What else can we do to these patients?
If the antibodies are positive, then you probably just treat them. It is just that they are autoimmune. They are stabilized at that point. Maybe they will go into overt hypothyroidism later.
But they're being treated already. They're already on levothyroxine, let's say 88 mcg or 100 mcg.
And their TSH is
and the TSH is still high. And these are the people who always took it. And in fact, I do this direct observation treatment therapy for some of them who may be non-compliant. But these are not the non-compliant set. These are the educated lot who have been taking it, and repeatedly their FT4 is normal. So initially when they came to me, of course, there was overt hypothyroidism, TPO antibodies were high or not high or whatever, but now they're treated well, and they're under your care for years together. And the TSH is still high. It's not so high like 100. And it is not so low like 6 and 7. It is properly high, like 20, 25.
But you wouldn't increase the dose because...
I don't want to increase the dose because of the FT4 is normal. And in some patients, I've increased the dose of LT4, the levothyroxine of whatever you've been prescribing. And that resulted in a higher FT4 and more of a hyperthyroid symptoms. So I was not happy with my tweaking up of the dose. Patient is not happy, FT4
So
is not
true. I
happy
agree
also.
that some
And in
patients-
those cases, the
may
TSH
be-
did come down a bit. But
maybe
still
require a
again not normal, not in
genetic
the normal zone. Again
analysis in
high.
that patient. Yeah, okay. We can
Yeah.
probably do a subset
It's
analysis.
more of a higher endocrine group talk, I mean, where we could discuss in our ESI or someplace, but that has been a problem.
Can
No,
I
good
just
point.
add to that? I mean, if the patient is symptomatically okay with a normal free T4 and free T3, once you cross the weight-based dosage, I think you really need to think around the territory of either there's something wrong with the TSH assay or whatever, or it's compliance issue. But then if symptomatically normal beyond the weight-based dosage, I don't think we should keep on increasing the dosage.
Yeah, exactly. So that's the calculated dose. We have to come to the point and then again optimize.
I'll move on to the
PS.
next session. Dr. Ravi, please take us through hypogonadism. Please come. Just the nuances.
the PSA levels again when monitoring the testosterone treatment.
Thank you. We'll move to the next session. Dr. Prithviraj, he's a consultant endocrinologist at Magna Center, Kokapet and Eret Hospital, and he'll take us through what is hyperprolactinemia and why is it not always a prolactinoma. We know we all have these cases where prolactin is slightly high. What to do with these samples? So go over to you.
Thank you, sir. At the outset, I would like to thank the organizing committee and Kalyan sir for this opportunity. If you look at the topics in this session, my topic is the little bit easy one. Hyperprolactinemia, why it is not always a prolactinoma. And the incidence of hyperprolactinemia is very common. If you look at the numbers in the observational studies, it's shown around 10% of the female randomly, if you sample, there can be a mild elevation of prolactin. So whenever a patient walks into your clinic with a anxiety and with an elevated prolactin level, you should need to repeat the prolactin test and reassure them. Majority of the times it may be normal when we repeat it second time. Prolactin, we all know, is a milk producing hormone, especially in mothers, and it has its own feedback mechanism. It is continuously inhibited. The pituitary is continuously tonically inhibited from the hypothalamus with the secretion of dopamine. Whenever this continuous inhibition is lost, prolactin can be elevated. This continuous inhibition can be lost in physiological causes and the pathological causes. And we all know that the continuous inhibition comes in the form of dopamine. When there is a decrease in dopamine levels or insensitive to dopamine levels, then there can be a disruption in the transfer of this dopamine hormone. Then we can see the increased prolactin secretion in our patients and increased lactotroph stimulation. So these are all the pathological conditions that can cause at the hypothalamic level, which can cause tumor, sarcoidosis, radiation, can cause disruption of the tonic inhibition of pituitary to produce the prolactin, and stalk compression and other causes I will be discussing in detail. Sorry. So this is how the tonic inhibition goes from hypothalamus to pituitary. When the inhibition is pulsatilely disrupted, again the lactotrophs, usually 15 to 25% of the pituitary cells may grow and may cause hyperprolactin or prolactin secretion in a normal people also physiologically. So coming to clinical manifestations, in a female it can present with irregular menses, amenorrhea, galactorrhea, anovulation, infertility. In the men it can present with decreased libido, erectile dysfunction, hypogonadism, and majority of the chronic hyperprolactinemia can cause osteopenia or osteoporosis. And macroprolactinemia, especially giant prolactinoma more than 4 centimeters, can present with mass effects like headache, visual field defects, and ophthalmoplegia. So this is the etiological framework I am mentioning about. If a patient comes with increased prolactin levels, we need to look at whether how much it categorizes, whether it is a mildly elevated, moderately elevated, or severely elevated. Majority of the conditions it is mildly elevated, less than 50. More likely it is more than 90% of the times it is more physiological. These are the physiological conditions that can cause this hyperprolactinemia: pregnancy, lactation, stress, or nipple inflammation, or any chest wall injuries or chest wall disorders. And again, now we can see more and more of psychiatric illnesses and use of more of psychiatric medications, and the pharmacological cause of hyperprolactinemia is very common nowadays, and we need to be cautious in probing the medications that they are taking, especially they come up with moderate or mild. In very rare cases, sometimes very severe hyperprolactinemia also. We can see in especially some drugs like risperidone, levosulpiride, the prolactin may go up to 150, sometimes 200 also. So we need to keep close eye on the medications they are taking. And the third cause is the systemic causes, and we all know hypothyroidism can cause the hyperprolactinemia. The thyroid releasing hormone from the hypothalamus can cause lactotroph hyperstimulation and cause the prolactin elevation. So if a patient walks with both elevated TSH and elevated prolactin, I will correct his or her thyroid first and gradually keep a tab on her prolactin, and then think about the whether they need further evaluation or not. Same in the case of CKD, there can be decreased dopamine or decreased filtrance of prolactin, so prolactin can be mildly elevated. Same with PCOS, we all know is the hyperestrogen state, and estrogen again acts on the pituitary level to produce a mild prolactinemia, hyperprolactinemia. Coming to pathological causes, most of the times it is prolactinoma, prolactin secreting tumors that are 20% of the functioning pituitary tumors, 40% of the functioning pituitary tumors. And sometimes it can be any mass lesion causing the stalk effect, disrupting the dopamine and the donic inhibition, causing to elevated prolactin. So, two important points we need to consider whenever we are evaluating prolactin is, sometimes it can be macroprolactinemia. The patient may be asymptomatic completely. The patient may be getting her periods regularly. She is not having galactorrhea, no headache, no symptoms, but comes with a prolactin of maybe 60, 70. So we need to repeat the sample. Again, if it comes in the same range, we need to consider this macroprolactinemia, especially on the background of asymptomatic presentation, because in the 4% of the population, IgG antibodies against prolactin can be positive, and they can bind to monomeric prolactin levels of prolactin and can show falsely elevated total prolactin values. With the PEG precipitation, we can filter this and we can find out the actual prolactin in these patients. So 4% of the patients can have these antibodies, so we need to be cautious while evaluating the hyperprolactinemia. And again, the hook effect. Especially in giant prolactinomas, patients having huge masses of 3 centimeters, 4 centimeters, pituitary adenoma, functioning pituitary adenoma, the prolactin may come low in comparison to the size of the adenoma. This can happen because of oversaturation of the antibodies in the assay we are using. So to avoid this or to overcome this hook effect, we need to dilute the sample and run the sample to look at the actual numbers. Why it is important is, it is important in actually treatment of the patient. We need to monitor the dosage of their dopamine agonists depending on their fall in prolactin values. To simply put it, it happens, it's not small as it looks like. It's a very big tumor. If we are expecting more than 1000 prolactin, but it comes in the range of 200 to 500, then you need to repeat the prolactin in 1:100 dilution to look at the absolute value of the prolactin, and based on the baseline prolactin, you can start your treatment and taper or increase your medication based on the decline in the prolactin values. As a thumb rule, for any prolactinoma, we will do a dilution for most of our patients. And coming to approach to hyperprolactinemia, the first step is always going to repeat the prolactin test, especially in the morning fasting after half an hour of waking up, at least after 1 hour of waking up, because the prolactin normal rhythm, circadian rhythm, usually peaks in the hours of 4 to 6 a.m. And after getting up from bed, after at least 1 hour, without any intense exercise, in a fasting state, try to repeat the prolactin. Majority of the times, mild to moderate prolactin, hyperprolactinemia can come back normal if you repeat it on the second time. This is very common in our practice. And if even it is still high, you can rule out the physiological causes of pregnancy and all. And if it is still high, then you think about ruling out the prolactinoma by doing the MRI pituitary. But if the baseline prolactin itself is more than 100 or 200, and if you can able to rule out the drugs causing these conditions, you can directly go to the MRI pituitary to look for the prolactinoma, especially on the background of if they are having symptoms like galactorrhea, irregular menses and all. And consider the treatment according to the cause. And again, majority of the times we have this confusion in the endocrinologists also, whether the mild to moderate hyperprolactinemia and the microadenoma, is it a stalk effect or is a microprolactinoma? How to differentiate this, whether it is a non-functioning pituitary adenoma with stalk effect or it is a microprolactinoma. Usually prolactin is very much in synchronous with the size of the tumor. If the size of the tumor is more, prolactin will be on the higher side. If the size of the tumor is less, prolactin also usually correlates with it. In the stalk effect, usually the prolactin may not go beyond 100 in most of the cases. In very rare cases, it may go up to 200. This is important because to treatment, if it is a non-functioning pituitary adenoma, we may consider wait and watch approach, or if it is more than macroadenoma, more than 10 centimeters, we may consider surgery. But if it is a microadenoma, most of the times, if the prolactin is only mildly elevated, we can think about giving a trial of therapy or wait and watch based on the patient circumstances and symptoms. So to conclude my talk, if I have to conclude, don't read the reports, treat the patient. First check for the clinical history whether they are having any signs of hyperprolactinemia, especially irregular menses or infertility or galactorrhea or any headache or anything. And even if the repeated prolactin is high and the drugs are ruled out, then consider doing the MRI and consider the treatment accordingly.
Quick couple of questions. Are we underusing macroprolactin in our practice?
I think it depends on how your practice is, because if you don't know about it, then you wouldn't be checking for it, isn't it? So the point comes as to say is that how frequent you're seeing it and what is the level of suspicion. So that's the key there as to say. That's always I say, we're back to the basics of history. And I always see a lot of mild raised prolactin with PCOD, and again, they've been treating. So the point is, what is your level of suspicion? What are you thinking? Because he's really clearly pointed out that with a big pituitary size, sometimes you can get low prolactin as well. So the point is, what are you looking at?
Smita, women planning to conceive come with mild hyperprolactinemia. Gynecologists always put them on cabergoline.
Yeah, absolutely. I think most of them get started on cabergoline anyway. But yes, once again, the clinical context, and obviously subfertility is also a symptom of hyperprolactinemia. But the level of prolactin itself, whether they have other factor like PCO or PMOS, which is contributing to it, and the fact that if we are going to start them on cabergoline, we are not going to continue it during the pregnancy. So if the patient does fall pregnant, unless the levels are very high or there is a diagnosis of a prolactinoma, I don't think we need to rush and start.
Yeah. So I'll just tell you one real life scenario. Yesterday a patient came to me, she put a chat GPT saying prolactin causes acne. Chat GPT is very, it tells you what you want to do. Yes, absolutely. Prolactin can cause acne, and she was very adamant that her acne is because of a prolactin of 35 or something. So I had to really, so a lot of patients have a very bad misconception about high prolactin causing this and that. It is not true. Only thing what it causes is what Dr. Prithvi has said. So with that, we'll just move to the next session. Dr. Smita, she's going to talk us through